Eeric Truumees. I'm an orthopedic spine surgeon. I currently practice in Austin, Texas. I've been there about 8 years, and one of the most frequent questions I've gotten since moving there is, how is my practice there different from the orthopedic group practice I had in my previous 12 years in Michigan? And we have a interdisciplinary spine practice, and I thought it'd be very useful to go over kind of the pros and cons of that kind of practice with my partners, who all come from different backgrounds, whether it's academic practice or a neurosurgical group practice. And I thought we'd start with Dr. Stokes. And how did you start this group practice? It was well underway when I got there.
So the way that we kicked this off, and some of the problems that we were trying to solve were the spine care in the community was very fragmented. A lot of our referrals came from family practice. A lot of our referrals came from pain management in various stages of the diagnostic workup. And we thought it would be very beneficial for both the patients and the physicians to develop a system in which the patients benefited and the physicians benefited from kind of a streamlined process. So I came from a general neurosurgery practice where, like I said, the stage of the diagnostic workup was from no workup to ready for surgery. And what we wanted to put together was a process that, again, streamlined that. So the way that we did it was I came together with one of my orthopedic spine colleagues in the community. Actually was probably my main competitor in the community. And then we merged with 2 physical medicine and rehab physicians and developed a process, a triage process for the patients when they come into the office to make sure that they get placed with the right provider. And the way that that works is, say a patient calls the office for an appointment, the first people they talk to are the triage nurses. And the triage nurses are educated in the triage process. And what they do is take a basic history and then place the patient with the provider that is most likely to fulfill their needs.
Thank you. Dr. Pena, you got there just before I did. What was attractive to you about an interdisciplinary practice coming from an academic practice in Boston?
Well, one of the strengths that I noted was that in my previous practice, it was a group of well-trained physical medicine rehab doctors like myself. However, I always found that when I needed access and input from the surgical side with difficult cases, or cases where it really wasn't clear, where are we going with treatment with this patient, that it would have been very valuable at that time to have some direct access to surgeons and their point of view, their opinion, to optimize. So I found that being in a practice that had essentially very direct communication between non-surgeons, medical spine specialists, and surgeons really optimized my ability to be able to take care of these patients, not just offer them what I had with respect to medical management, interventional pain management, but also be able to quickly access a surgeon when I felt like I needed that, when my patient needed that. So I think that's one of the main strengths.
So ultimately what I'm hearing is, from a surgeon's standpoint, patients that aren't ready or wouldn't need surgery are seen by non-operative specialists who are in the office more often, have more time and interest in those issues. From the PM&R perspective, having backup from surgeons for cases that need more immediate surgery makes for a more comfortable practice environment, maybe better utilization of time and energies. Dr. Mayer, from the patient standpoint, what do you think the benefits of an interdisciplinary practice might be?
So I'm Kano Mayer, and I'm an interventional physiatrist, and I practice with these folks. I think what's most helpful for the patients is time to diagnosis and treatment. And so often with a multidisciplinary practice, you are getting bounced around from doctor to doctor, not really with an effective treatment plan, waiting in between each visit, not clear as what the path is. And I think what we have here is we understand each other's indications, we have less variation in care, and I think we can be very clear and transparent to patients, manage their expectations, and decrease the time that they lose function, that they lose work, that they're not employed. And I think that for patients in this era of value-based care, this is not a population health where we're trying to fix a population. We are specifically enhancing the efficacy of care for the individual patient. And it's going to take some unlearning for patients to go from the old model of just bouncing around by Brownian motion to actually getting into a place where they know that the diagnosis and the treatment plan is going to get done right the first time.
I think from the physician's perspective, there's some efficiencies, but certainly from the patient's perspective as well. You don't have the 8 forms to fill out for each doctor, or probably 80 forms at this point. You have one practice, the information's exchanged. There's a lot of limitation in terms of how much duplication of effort you'd otherwise see. But with people coming from very different training backgrounds, very different philosophies, even within spine surgery, there are a lot of controversies. How do you make a group practice work, Dr. Pena?
Well, I think one of the most effective tools really is communication. The two-way communication between the surgeon and the non-surgeon. I think that lends itself towards shared treatment philosophies. It allows each physician to play to their strength. A non-surgical specialist will be optimally able to treat that patient with a skill set and utilize that skill set the majority of the time, and then the surgeon will do the same, because the surgeon need not medically manage the patient then. And so if the physician group is able to communicate, conference, co-manage, and discuss the patients, then each time the patient's going to receive the most optimal level of care that that physician has to offer. So I think the key in general is kind of the commingling of ideas and the ability to have that back and forth that you can have when the group is both philosophically and physically together, practicing together.
Dr. Stokes, any thoughts on that subject?
Yeah, I think just to elaborate on that a little bit, I think the same concept applies within the surgeons in our practice as well. For instance, Dr. Pena talked about, playing to the strengths of the provider in the surgical versus the non-surgical world. I think that even in the surgical world, the patient can be triaged or directed to the surgical provider, depending on their condition, that has the most experience with treatment of the particular problem that they have. For instance, some of us may be more interested in a deformity type practice. Some of us are interested more in a degenerative type practice. Some of us are more interested in tumor, trauma, et cetera, and the list goes on and on and on. And I think that having surgeons, within the practice that have different interests and are readily available for the patient to see on a day-to-day basis is a huge strong point of the practice.
I agree. I came into the practice with 12 years of experience, and I probably was egomaniacal enough to believe that I didn't have much more to learn. But in fact, I've learned a lot from all my partners, both on the non-operative and on the surgical side. As an orthopedic spine surgeon, having someone right next door who can help me out if a cord tumor comes in, for example, is a great benefit to my practice. And these are obviously very difficult circumstances where long delays don't help the patient's care. As we think about the process, I guess from a physician standpoint, it's a very efficient process because you're seeing those things you're really best equipped to manage, those things you're good at, those things that you've maintained a decent volume because you're focusing your efforts on these areas, and your care becomes better. as someone who doesn't do a lot of deformity anymore, our other partner, Dr. Geck, who's a deformity specialist, has the opportunity to maintain a great skill set because that's all he's doing. And you wouldn't necessarily be able to do that in a general practice where you have to take care of all comers to one degree or another. I think from the standpoint of starting a practice like this, agreeing on care pathways, conferencing patients, getting an understanding of where everyone is philosophically is a great way to make the system actually work. We all came in with different approaches and attitudes, but as time's gone on, while we all still have our differences, I think in terms of the big questions, appropriate non-operative management for disc herniation, for example, I think we've all come to a position where we're very similar in how these patients are managed. So when a patient calls the office, they're not going to get care based on who they happen to see. I've got this hammer, you're a nail. They're going to get the care that's really evidence-based and most appropriate for them and the provider that's best equipped to offer that care.